Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. It's my pleasure to be a part of this symposium today. In this session, we can have nice presentations by other speakers that provide us with relevant information about the current resistance in major gram-negative pathogens. My talk is not about the resistance in specific pathogens, but about the general overview of AMR surveillance. Why do you have to do the surveillance of AMR? This is a key question to answer in my talk. First of all, AMR is obviously a very serious global healthcare problem with a huge clinical impact. AMR issues have been one of the most urgent healthcare problems for the past 2 decades. According to data from UK, we may have at least 10 million deaths due to AMR infections worldwide in the year of 2050, which will be more than deaths due to cancer. Current COVID-19 pandemic has caused almost 5 million deaths worldwide. So if AMR continues to be getting worse, we will see far more serious disaster of AMR infections than current COVID pandemic in the future. Just like other contagious diseases, AMR can spread between countries and continents, as shown here in the case of KPC-positive Klebsiella pneumoniae. KPC-positive K pneumoniae has originated from India in 2008, but this pathogen has spread to all over the world for just 3 years. So this was not the problem of India any longer, but became a global problem. International spread of AMR clearly underlines the importance of international collaboration to combat this problem. No countries will be the exceptions to this global problem. And the surveillance of AMR can identify the emergence of resistance and to track the local and global spread of resistance. Although it's not clear that COVID pandemic directly affects the AMR problems, data show that almost 90% of patients with COVID infections were treated with early antibody treatment without objective evidences of bacterial infections. But actually, only 7% of COVID patients were found to have bacterial co-infections. So antibacterial agents are obviously abused or misused in most of the cases, and this will lead to the emergence of resistance later. AMR surveillance is done to detect resistant pathogens and follow their spread among geographic areas to enable correct decisions for treatment, to guide the policy recommendations, and to monitor the effectiveness of measures taken to combat AMR, as well as to track the use and misuse of antimicrobial agents. Actually, all different measures to combat AMR should be based on surveillance of AMR. Based on the data from surveillance, we can get to know the current status and magnitude of AMR problems. We can make a correct diagnosis of bacterial infections caused by resistant strains. We can develop new antibodies that can be effective against resistant pathogens. We can prevent the emergence of resistance. And finally, we can make relevant policies and recommendations to combat this problem. So without AMR surveillance, we cannot implement any measures to control and prevent AMR problems. More specifically, AMR surveillance data can be used to define the scope of AMR problems, to carry out antibody stewardship to improve the appropriate use of antibodies, to decrease the selective pressure for the emergence of resistance, and to understand the mechanism of resistance, which can be used for discovery of novel antibiotics. So it's quite obvious that AMR surveillance is really the first step toward the control and prevention of AMR. Let me shift gears to the actual AMR surveillance system and programs worldwide. AMR surveillance can be done in different levels, such as global, regional, and national setting. If we see current surveillance programs which are being implemented at this point, we can have more insight into the role of surveillance. First, I'll briefly summarize the global surveillance of AMR by WHO. WHO announced the Global Action Plan to combat AMR in 2015. I have joined the special committee of WHO, STAG AMR, to prepare this. WHO Global Action Plan includes 5 major strategies: increase the awareness of resistance, perform the surveillance and research, reduce the incidence of bacterial infections, optimize the use of antimicrobial agents, and ensure sustainable investment in combating AMR. Although all of these measures should be implemented at the same time, surveillance is really the first measure we have to take to identify the current status and problems of AMR. WHO proposed the Global AMR Collaborative Platform to combat AMR. Each member state of WHO should establish the local and national system to perform the local and national surveillance of AMR and antimicrobial consumption. Since AMR can spread between countries, international collaboration is very essential to combat AMR. So regional international network is another key factor for effective control and prevention of AMR. We have a couple of international programs of AMR surveillance in different continents, as shown in this map. And finally, WHO wants to establish the global AMR surveillance platform based on these local, national, and regional programs. For this purpose, WHO has launched the Global Antimicrobial Resistance and Use Surveillance System, or GLASS, in 2015, which is the first global collaboration to standardize the AMR surveillance. GLASS has 3 technical modules. Routine data surveillance includes GLASS AMR for AMR surveillance and GLASS AMC for antimicrobial consumption surveillance. Focus surveillance includes GLASS EAR for emergence of new resistance and GLASS fungi for Candida species AMR surveillance. Also, surveys and studies of GLASS includes various programs including gonococcal surveillance, One Health surveillance, point prevalence survey for antimicrobial use in the hospitals, and the evaluation of mortality in patients with BSI caused by resistant pathogens. This is the data from GLASS report this year. As shown in this map, AMR surveillance system has been established in many countries around the world, but only a few countries were enrolled in both AMR and AMC surveillance. Also, we still have missing pieces for this global surveillance system. For example, in the Asian region, China is not enrolled in this global surveillance system for now. For GLASS program, surveillance sites in each country are doing the local surveillance of AMR, and data are analyzed by national reference labs and national coordinating center, which are sent to GLASS of WHO. GLASS is focusing on 8 major bacterial pathogens from 4 major specimen types as shown here. Among WHO regions, Western Pacific region, African region, and South America are still underdeveloped in establishing the national coordinating centers for GLASS. The promising sign is that we can see the increase in the number of countries with the national coordinating centers in most regions. GLASS provides the global outlook of current status of AMR in the regions and countries. For instance, it can analyze the current status of AMR based on the economic status of countries. In terms of BSI, low and middle-income countries showed higher prevalence of third-generation cephalosporin-resistant E. coli or MRSA than high-income countries. Also, GLASS analyzes the difference of AMR status between community and hospitals. As shown here, UTI caused by Cipro-resistant E. coli and Klebsiella pneumoniae were more common in the hospitals than in the community. You can find more details in the GLASS report, which also provides the current status of AMR surveillance system in individual countries. This is an example of Singapore in the GLASS report. So major roles of global surveillance by WHO include, first, to provide a global outlook and current status of AMR surveillance systems in the world. Second, to promote and encourage the international collaboration to combat AMR. Global surveillance efforts by WHO should be more effective and efficient to include more countries in this program, which otherwise do not have interest in this problem. I believe that COVID-19 pandemic gave us very important insight into global disaster by infectious diseases. And awareness of the critical nature of infectious diseases should motivate all countries in the world to actively join the global efforts to combat AMR. If you want to know more specific data from each region or country, we need to do the surveillance at regional or national level. We have a few regional surveillance programs by continent at the moment. These regional surveillance programs can provide more specific data on AMR based on the regional situation, and it could be a more effective way to communicate with the participating countries. We have just a few regional surveillance programs organized by nonprofit organizations as shown in this map. In the American continent, PAHO and LABRA are doing the multinational surveillance of AMR. In Europe, ECDC has organized EARSnet and the Central Asian and European surveillance system for this purpose. In the Asian region, we have the Asian Network for Surveillance of Resistant Pathogens, or ANSORP, which was organized by Asian physicians, and WPARS, which was organized by Western Pacific branch of WHO. And actually, there are a couple of international surveillance programs which are organized by pharmaceutical companies. Let me briefly talk about ANSORP in Asia. I have organized ANSORP in 1996 with Asian physicians. When I have first organized ANSORP, we had only 14 hospitals for this program. For the past 25 years, ANSORP system has been continuously expanded, and as of this year, ANSORP has 126 hospitals in 71 cities of 14 countries in Asia and the Middle East. Through this huge international network in Asia, ANSORP has been providing data and information about AMR in the Asian region for the past 25 years. ANSORP surveillance program is one of the international programs by the Asia Pacific Foundation for Infectious Diseases, or APFID. I have founded APFID to coordinate and support the international activities to control and prevent AMR and infectious diseases in the Asia Pacific region. There are 5 major international programs by APFID. ISA is an international symposium every 2 years. iCare is an international campaign program to increase the awareness of AMR in the region. Asian Bacterial Bank is to collect major bacterial isolates from Asian countries for research. IDRI is doing the basic research about AMR. And finally, ANSORP is doing the international surveillance of AMR in Asian countries. ANSORP Group has been carrying out many multinational surveillance projects since 1996. The first ANSORP project from 1996 was the surveillance of pneumococcal resistance in Asian countries, which had been serially repeated and provided the longitudinal changes of pneumococcal resistance in Asian countries. We have also performed the surveillance of other pathogens and some important diseases, such as community-acquired pneumonia and hospital-acquired pneumonia in Asian countries. Also, ANSORP has established the ANSORP Pediatric Group since 2015 and performed the surveillance project. The current ANSORP surveillance project is the surveillance of carbapenem-resistant gram-negative bacilli, which will be done for the next 2 or 3 years. Based on these ANSORP projects, we have published more than 200 papers in international journals, and data from ANSORP studies provided relevant and critical information and insight into AMR in the region. This is an example of the ANSORP projects. We have done serious surveillance studies on pneumococcal resistance in Asian countries since 1996. These serial ANSORP surveillance studies show the temporal changes in pneumococcal resistance, such as erythromycin resistance, and the changing pattern of serotypes of Strep pneumoniae in Asian countries. Finally, I'll briefly touch on the national and local surveillance of AMR in individual countries. This is the most basic and essential surveillance of AMR. Every country might have the different healthcare system, prescription pattern, regulations, and social situation. So they could have unique problems of resistance. But global or regional international surveillance programs may not be able to reflect the specific local situation of resistance. So every country should establish a national and local surveillance system of AMR. National surveillance framework should be based on 2 major governmental systems, the Ministry of Health and Ministry of Agriculture, since One Health surveillance, including both human and animals, is essential to have more comprehensive insight into AMR problems and more effective ways to control AMR. This national framework was proposed by WHO, and each country can customize the programs based on the local situation. Basically, the national system consists of national reference labs, which are coordinating the hospitals, community center labs, public health services, as well as food center labs and vet center labs. Let me show you a couple of representative national systems for surveillance of AMR. The United States has announced a national strategy to control and prevent AMR in 2014. It includes 5 major action plans, and One Health surveillance of AMR is one of the key strategies to combat AMR. According to the national strategy, US CDC and FDA have activated various national systems and programs such as NARMS, GISP, or NHSN. UK has also announced its national strategy in 2014 as shown here. The UK strategies include developing innovative drugs, diagnostics, vaccines, and new therapies, as well as the surveillance of AMR. And obviously, surveillance is the basic step to implement all of these measures. In the Asian regions, a couple of countries, including Korea, Japan, China, India, Vietnam, the Philippines, Malaysia, Singapore, and Australia, have organized the national surveillance system as shown in this map. These national surveillance programs have been doing the national surveillance studies for major pathogens and they have reported the data in the local and international journals. These national surveillance programs obviously contribute to increase the awareness of AMR and to make relevant policies and strategies to solve the problems. Let me show you one example of national surveillance programs. I think that AURA, the antimicrobial use and resistance in Australia, is one of the most comprehensive national surveillance systems. AURA is doing both AMR surveillance and AMC surveillance. Both surveillance programs consist of targeted surveillance and passive surveillance in the community and in the hospitals. Many organizations and networks in Australia join this program as shown here. For antimicrobial consumption surveillance, AURA analyzes total hospital antibody uses and also evaluates the appropriateness of antibody prescription in Australia. This data on antibody consumption can give us very important information on the current status of use and misuse of antibiotics, and it can be the basis of antibody stewardship, as well as making relevant policies and recommendations for antibody uses. AMR surveillance of AURA is also providing current status of AMR in major bacterial pathogens as shown here. They provide temporal changes of resistance in these pathogens. So if national surveillance can be effectively performed, it can provide very useful information which are needed to combat AMR by individual countries. Also, this would be the most appealing and relevant information to local physicians and practitioners. So as I presented, we have AMR surveillance programs at global, regional, and national levels. These programs provide useful data and information about AMR, but we can improve the current surveillance programs for more effective control and prevention of AMR. The basic problems in many low and middle income countries is they don't have competent reference labs, adequate infrastructure, and data management system for accurate surveillance. Also, many of them are using non-standardized methods for surveillance. Due to these basic problems, we still do not have effective surveillance programs in many parts of the world. Also, intersectoral cooperation and international collaboration should be improved. These 5 major strategies to improve the surveillance were recommended by WHO. We have to collect and analyze not just AMR data, but also AMC data together. We have to share information and increase the awareness of AMR. We need to enhance the capacity building, such as establishing competent reference labs and national network. We have to improve the technical and human resources. This is also a very critical problem in many countries. Finally, we have to facilitate the networking and international collaboration. International collaboration can be facilitated by WHO and other international organizations, regional networks, as well as international networks by countries. Also, methods for surveillance are to be improved by using IT technologies and genomics. Also, surveillance should be based on One Health concept, including both human and animals. AMR surveillance should be integrated with antibody stewardship to improve the appropriate use of antimicrobial agents in the clinical practice. So in summary, AMR and AMC surveillance by global, regional, and national programs have very important roles in combating AMR. It can increase the awareness of AMR, promote antimicrobial stewardship, boosting discovery of new antibodies and novel diagnostics, especially POCT, and provide relevant information for building the relevant policies and systems. When all of these measures based on surveillance are successfully implemented, we can see the decrease in AMR that can save millions of lives from fatal infections in the future. As Peter Drucker mentioned, if you can't measure it, you can't manage it. Thank you very much for your attention.